I'm excited to be with you all and to share with you some of the things that are coming out that are so just revolutionary to our profession. We see more change occurring in the last couple of years than I can remember for many, many years, having practiced for 34 years. What we're going to talk about today is the topic of bruxism, sleep apnea, and gastric reflux and how those connect. And as you see on your screen, in our teaching at the Dawson Academy, which we call the concepts of complete dentistry, we've always had a huge emphasis on occlusion, on the bite, and its relationship to the joints and the muscles, and trying to create a harmonious, complete masticatory system health. And we call that being the physicians of the masticatory system. What we're learning is that the masticatory system, as we all know, is not isolated, and it's part of a complete whole body system that has components to it that interact with what we're paying attention to. And so our model is expanding, and most recently, I would say in the last 10 years, even less, the subject of breathing disorders and sleep apnea has become more and more important to us as we recognize that it's a significant factor in stability of the masticatory system. And so we want to talk about that. And also, beyond that, also connected, we are going to discuss gastric reflux, which has a very close tie to breathing disorders and also to lifestyle issues, as I'll point out to you, because there's a connection there even with our diet. And so we're going to talk about those three. Those three are part of, along with bacteria, what we call the 4 Bs, and the 4 Bs are part of what we are describing as integrative dental medicine. So we know that integrative medicine is becoming a growing topic around the country, and there are many universities and centers of medicine that are opening integrative medicine departments, even complete centers that are dealing not only with the isolated problem the patient may present with or the chief complaint, but also looking at the whole body and the integrative approach to dealing with not only illness, but the prevention of illness and the encouragement of total health. And so we're going to piggyback on that as we move forward and talk about integrative dental medicine as a topic that I think will become a focal point of the future of dentistry. So with that in mind, let's talk about this so-called triad, as Dr. Jeff Rouse in San Antonio has described it, the bruxism triad, the connection between sleep bruxism and what we observe as dental professionals, the wear and tear on the teeth, as well as abrasion. We also see erosion or cupping out of teeth as we see acidic environment presented in the mouth. That has been connected now with sleep disturbances in a high percentage of cases, which has also been connected with gastric reflux or stomach acid coming up. And so as we look at this, we're seeing more reports coming out, more research being exposed that's showing that sleep bruxism is a reflection of a trigger mechanism during sleep, so-called microarousals, which a percentage, it's estimated around 8% of the population experience, where there's a disruption not only of the opening of the airway, but there also can be a significant reduction in the pH in the esophagus. And these things work together to create an acidic environment, blockage of airway, a reduction of oxygen, and also parafunctional type activities that are responding to that. As we begun to do more studies with sleep, and in this case we're looking at a raw study of a polysomnogram, what you see here where the green is going across the first half of this graph is a flatlining of airflow, and we would call that, if it's more than 10 seconds, an apneic event where the person does not take a breath actively for 10 seconds or longer. We've seen cases where people have actually not taken a breath for as long as a minute and a half in our studies, and it's just astonishing. But with this flatlining of breathing, what you very often will find at the end of that apneic event, you'll see the breathing reestablished, often with gasping and movement of the jaw, rapid movement sometimes. And as you see in the red outlined above on your graph, you see bruxism activity. And that cyclically occurring over and over again, sometimes many times during the night. And during those bruxism episodes, you can have damage to the teeth. Now, this is something that we haven't been able to explain until now. As we talked about, why do people brux? We would say, well, it's a delta stage sleep disorder, neurologic, central nervous system generated activity. But there was really no good explanation. And we believe now that the idea of the precedent of oxygen trumping even anterior guidance in teeth is something that we're seeing manifested more and more and more. It makes me think back as someone who's been practicing for 34 years and doing a lot of major restorative dentistry, and especially with wear patients. I start thinking back on some of the patients that I've restored through the years, and here's a couple of examples. And you see significant destruction of the teeth, but also the $60,000 question is, why are they bruxing? What's provoking the bruxing? What is the cause and effect? And so it's very probable that in most of these cases that the subject of airway disorders and of sleep apnea could be a significant factor, certainly one that we need to investigate going forward on every single patient that looks like these do. Along with that, all of us that have done major restorative dentistry or any restorative dentistry on patients with wear, we know that it has been an automatic for us to recommend that if we're going to restore the occlusion that's damaged, we're going to also want to protect it. And so with that, it's been standard protocol for all of us, as long as I have been practicing, that we would make patients a sleep appliance, a centric relation, often upper, night guard to wear to protect the teeth after we've restored them, assuming that bruxism may continue. This study done in 2004 as a pilot up in Montreal, guided by several of the top researchers in the field of sleep dentistry and the dental management of sleep apnea, took 10 patients that were diagnosed with both snoring and sleep apnea through a polysomnogram. They made upper maxillary occlusal splints, CR splints for night guards, had those patients or subjects wear those night guards for 1 week every night, and then repeated the polysomnogram wearing the night guard. And to their shock, what they found was the apnea-hypopnea index was increased by greater than 50% in half of the patients. Snoring was actually increased by on an average of 40% wearing the splint. So the implication and the conclusion of that study is that the use of an occlusal splint, which we have all made many, it can be associated with actually aggravating the risk of respiratory disturbances like sleep apnea. So it suggests, and I would say maybe now it should be a protocol, that we as clinicians would question patients about snoring and question patients about sleep apnea, and even test patients for sleep apnea through home studies that are so readily available today whenever we're going to be recommending an occlusal splint for those that clench and grind their teeth. Another study done by Jeff Weiskarber, who's associated with WhipMix and the DDME company in Los Angeles, California, evaluated 14 patients before and after occlusal splint therapy and what effects that wearing the splint had on apnea-hypopnea index and bruxism. These were patients who had complaints that were related either to TMD problems or bruxism. These splints were made for protection of the teeth and using the normal protocols that the clinicians use day in and day out for that type of complaint. And then once the patients were acclimated to the splint, the bruxism monitor was sent home with them, and they were instructed to use that for a night and then use it again, that is the monitor, one night without the guard in, and evaluate the results. And you can see what they found is that the apnea-hypopnea index actually went up in 10 out of the 14 subjects. The bruxism bursts went up 8 out of 14 incidences. Bruxism episode index went up 9 out of 14 times. Oxygen desaturation, meaning the lack of oxygen flow, went up in 11 out of 14 patients, and the snore index went up 6 out of 14 times. And so that raises the question for me as a clinician who's seeing these types of patients every day, should this information cause me as a practicing clinician, as one who's trying to solve problems of these type, make it a protocol in my practice and in yours that we would screen and test bruxers for sleep apnea, that we would screen and test those that snore who may have sleep apnea, that we would have a protocol for screening and testing those with worn teeth, especially with erosive type, chemical type wear for sleep apnea that also may be associated with gastric reflux. So occlusal disease, as we would call cases like you're seeing here, frequently have significant systemic implications. This is the message that we've learned. When we see wear facets and erosion, and we see patients coming in with sore muscles and sometimes morning headaches, we may very well be looking at a reflection of obstructive sleep apnea and airway reflux. I would say now, Dr. Dawson, they're coming out of the woodwork, meaning we are seeing these left and right, just like many, many years ago we began to say TMJ type patients are coming out of the woodwork. And in fact, there's a great overlap between these two types of patients. So let's take a case study. This is Bob. I call him Bob the Bruxer. Bob came in, and you can see quite a bit of occlusal wear. He definitely has what we would call occlusal disease. He has abfractions. He has erosive wear chemically, as well as incisal and occlusal wear from parafunctional activity. So when we see a patient like Bob, at this point in time, we're going to be thinking about several things, and let's just call them the ABCDs of dental wear and bruxism. Number one, the first question that should come to my mind is, does Bob have an airway problem? And with that airway problem, I'm going to include gastric reflux because they so commonly go together. The second question would be, does Bob have a brain-mediated concern, such as drug-induced type hyperactivity that you see with amphetamines and different types of medications, or perhaps brain-mediated because he might have a disorder such as Parkinson's bruxism. So that could be a possibility for how someone could present with this picture of their oral condition. Another aspect is we don't ever want to forget occlusion, and so we've seen many people who have severe anterior wear because they have been restored or have a constricted anterior guidance. And so occlusally we certainly can see damage that is significant, as well as what I would call dysfunction of occlusion, which has to do with the discrepancy between the fully seated joints and the fully seated bite. So that hit and slide off the posterior teeth, it will drive the mandible anteriorly and drive right into those anterior teeth and cause wear and abrasion. So those are the things we're thinking about. With this discussion that we're having today, let's go back to the airway and question that. So how would we do that with a new patient? So a very simple screening form that you can use is the Stop Bang survey. 8 questions, super easy. You just ask the questions and the patient answers yes or no, and you add up the yeses. Do you snore? Are you tired during the day? Has anyone observed you stop breathing or gasping during your sleep? Do you have high blood pressure? Is your BMI more than 30? And what we do is we put the BMI chart, which you can copy off the internet, we put that on the back or the reverse side of this sheet of paper, and the patient can look and identify what their own BMI is. It's really helpful because it can, on a good graph, it'll say what obese is, and many people actually fall into that category, which is quite a self-discovery if that's not something that they have thought about, you know, in looking at themselves as just a little overweight. So that can be very helpful in getting into the whole health discussion as well. What is your age? Are you over 50? Neck circumference, is it greater than 16 inches? For women with a neck circumference greater than 16 inches and men with a neck circumference greater than 17 inches, there's about a 90% correlation with an airway obstruction during daytime and especially at night. So that's a great screening tool. And then gender, are you male? So if the answers to 4 or more of those 8 questions is yes, they're a patient who is at very high risk for having sleep disorder breathing. And if they're 3 or less, then that would be less likely. So anyway, we use this screening tool with every patient that we see. We spend about a year in our office taking this, having everybody that comes in our office for hygiene or recall taking this survey just as they're seated. And now we do that with every new patient as well. In Bob's case, he definitely came out positive for screening. So with a screening being yes or positive for sleep disorder breathing or tiredness during the day, then we would want to follow through with a true test. And today, more and more, it's becoming commonplace to do home sleep testing. It's a great thing for us because it makes it very easy for us in dentistry to get involved in this subject of sleep apnea and disordered breathing. So we're going to send Bob home with a DDME bruxism monitor, which is supplied to you by Whitmix, and it's very simple to put together. We'll show the patient how to do that. They'll take it home. They'll be able to sleep in their own bed. This is not nearly as cumbersome as going to a laboratory or a hospital to have this study done, and we get the information that we need. Also, the patient sleeping in their own bed, and so it's a much more natural night of sleep. More and more insurance companies now are recognizing the great benefit of home monitors and are approving those for use for studies of, for sleep disorder breathing. And so it's something that we're finding less patients going to sleep labs and more patients doing home studies than ever before, and that's the direction we're going. Just a side note, I had one sleep physician who was a real purist about doing studies in the hospital, and I showed him a home monitor and how it worked. He didn't believe in them at all. I showed him the results compared to a polysomnogram that had been done previously for a patient in the hospital, and as he looked at the raw study that we did with the home sleep testing versus the polysomnogram, he had to conclude that it was extremely accurate and just as accurate as what was being done in the hospital. This very busy sleep physician now has 12 home monitors that he uses in his practice and sends home with patients on every single day. So this is becoming standard medical protocol in evaluating and testing for sleep apnea. So what about Bob? When we sent him home with the bruxism sleep home test monitor, if you understand that AHI, which is apnea-hypopnea index, a way of getting a feel for what's going on during sleep, the normal recording or reading would be less than 5. That is, less than 5 episodes on average per hour throughout the night of times when the patient may stop breathing for a minimum of 10 seconds. If they do that on average 5 to 15 times per hour throughout the night, that's considered mild sleep apnea or AHI. Moderate is 16 to 30 times per hour on average, and severe is greater than 30. as you may be able to see on your screen, and I'll highlight this here, Bob was 55.4. Bob not only had sleep apnea, Bob had a very dangerously high sleep apnea that literally could have killed him in his sleep if his heart had stopped because of his severe oxygen desaturations that were occurring many times throughout the night. Along with that, then what we're going to do with a finding like this is, in this case, what we did was we had a board-certified sleep physician review the study and verify that this was an obstructive sleep apnea and not a central sleep apnea, which has to do with the respiratory system not making an effort to breathe, which is different than the airway being blocked. And so a very important diagnostic aspect of this. So a critical part of this discussion is that we in dentistry, we do not diagnose sleep apnea. So even though we ran this test and we got a report back and it gave us a result that would lead us toward a diagnosis, this is a very incomplete diagnosis to just say, well, your AHI is 55. There's so many things that underlie that report or that are within the raw study that needs to be looked at. So we would take this report and ask the certified board sleep physician associated with DDME, the company who we are running this study with, to review the raw study and give us a written report. Once we did that, and it was deemed that Bob was willing to work with us on a pilot program, which is what we were engaged in here, we went to this interim oral appliance device, also made by DDME, called the BRX Pro, and I've used this quite a bit. It's very simple. If you all have used any oral appliances for sleep, and you're familiar with the TAP appliance out of Dallas, Texas, this is very similar to the TAP in that it has a hook and a little latch that go together in the front, and you can move the upper and lower individual plates. You can move them forward and back relative to each other by just putting it in different hooking slots. And what you do is you just take bite registration material and reline the upper and then reline the lower, hook them together in a protruded position. Usually we'll go about 50 to 60% of the patient's maximum protrusion, and you've got an instant sleep appliance that can be used to test out what kind of improvement you'll find. Improvement that relates both to opening the airway by moving the mandible and the tongue forward, but also improvement that has to do with the fact that the back teeth on this appliance do not touch. So we're hooked in the front, but nothing else touches. So we're basically making a discluding element in the front to separate the back teeth so that if Bob does want to clench, it's very difficult for him to do that effectively. He can only use his elevator muscles maybe 20%. And so we're opening up the airway, as you can hear. Look at the position of the teeth as we go from maximum intercuspation to, in this case, a slightly crossover position. And if you look at the diagram of the airway, you can see the airway is significantly opened. All right, so Bob wore this appliance for a week. And after 1 week, we repeated the home study. And the home study revealed after 1 week that his AHI had gone from a very severe 55.4 to a middle range mild AHI of 11.8. When we look at his oxygen desaturation index, which is how often is his oxygen level lowering to a point that would typically be below 90% saturation throughout the night, Bob's levels were sky high and dangerously high during the night before. After we wore the oral appliance, actually his oxygen desaturation levels were acceptable because his 11.8 AHI is probably more H than it is A, meaning it's probably more shallow breathing than the cessation of breathing altogether. Also, if you look at his overview of his bruxism, which we were studying as well, his bruxism burst went from 295 during the night to 39. So you can see his parafunctional activity has dramatically dropped as his airway has been opened, and also as we have used an appliance to make it more difficult for him to brux. His longest bruxism burst was 46 seconds before treatment, and it was 14 seconds after treatment. So you can see we've dramatically turned around not only his parafunctional activity, but we've literally turned his health around. So we're going to use that as our #1 priority of his overall health. We went ahead and worked with Bob's very damaged occlusion. We chose in this case, through Bob's decision, to work with composite restorations, which we were able to restore incisal edges, facial surfaces, restore his occlusion to establish a good CR, anterior guidance occlusion. But this is not going to eliminate his apnea. And so in Bob's case, what we decided to do was to make a more definitive oral appliance that he would wear every night. We've monitored that, and his AHI with the oral appliance in has even been improved over our test appliance, and now we've been able to idealize our titration or positioning of the lower jaw to where we're maintaining an AHI below 10, which is very, very manageable. The other thing that we've done, and this gets into the breathing subject, is we actually, for a couple of months, about 3 months, work with mouth taping. Now, this is a fascinating topic. It's really getting a lot of attention now in the States. It's been something that's been used in Russia and in Europe, especially Ireland, over many, many years, literally more than 40 years. For the idea is to tape the mouth shut to force the patient to breathe through their nose. Because, as I'm going to show you in a minute, we're learning that nasal breathing is very strongly related to health. And mouth breathing is very strongly connected with illness. And so this is something that we want to pay attention to and start integrating into dentistry in our therapies as we're working with some of these disorders. Another thing that we're aware of is that there's much research about gastric reflux, which Bob had, and the fact that gastric reflux is strongly associated with a Western acidic diet. And I'll mention a little bit more about that as we talk about reflux. But this book is one I highly recommend to you. I love the title, Dropping Acid, The Reflux Diet. This is Dr. Jamie Kaufman, K-O-U-F-M-A-N. Dr. Kaufman is a physician in New York City and is considered one of the, if not the world authority on gastric reflux, and is a gastroenterologist. And so this book explains some principles on the cause and effect relationships of gastric reflux and the treatment, which I'll describe to you. So let's talk about oxygen a little bit. This book is another one that I highly recommend to you, The Oxygen Advantage by Patrick McKeon. He is in Ireland. The Oxygen Advantage is one that talks about, and I'll just read this quote to you, that upper airway resistance, which is the same idea as obstructive sleep apnea, during sleep, and the propensity to obstructive sleep apnea are significantly lower while breathing nasally rather than orally. And this mechanical advantage may explain the preponderance of nasal breathing during sleep in normal subjects. So why is that? What are the advantages of breathing through your nose? And what has been discovered physiologically is that when you breathe through your mouth, you tend to hyperventilate. In other words, you tend to blow off a lot of carbon dioxide out of your lungs. And when you do that, what happens is the carbon dioxide levels in your blood go down, and when the carbon dioxide levels in your bloodstream are low, there's a balance, the so-called Bohr effect. There's a balance in your bloodstream between carbon dioxide and oxygen. When carbon dioxide is low in your bloodstream, oxygen tends to stay in your bloodstream rather than moving out of the bloodstream into your tissues. When carbon dioxide is high in your bloodstream, then that causes, through the Bohr effect, the oxygen to be forced out into the tissues, into the brain, into the heart, into all the cells of the body. And so you're going to be healthier when your carbon dioxide levels are higher in your bloodstream and the oxygen is actually in your tissues, not in your bloodstream. So breathing through your mouth reduces the carbon dioxide in your bloodstream, which reduces the oxygen delivery to your cells. So the idea of breathing through your nose is you're controlling the exhaling of air, and with that the exhaling of CO2, thus building up more CO2 in the bloodstream and forcing more oxygen out. So you're increasing red blood cell production when you do that. You're improving oxygen delivery to the tissues. There's a EPO hormone that stimulates cell coming from the kidneys. It stimulates stem cells in your bone marrow to create more red blood cells. So when CO2 is higher, EPO stimulates more stem cell production of red blood cells, so thus there's more red blood cells. You're basically blood doping legally. You're filtering also, as you breathe through your nose, airborne pathogens. You're unblocking nasal congestion. You have nasal congestion and you actually force yourself to breathe through your nose. In most cases, the nasal congestion will actually clear up. It improves your overall breathing and lung function. In many cases, it will cause asthma-type symptoms to go away, and it increases your lung volume. Many athletes are using taping today, taping of the mouth when they're training to improve their performance, to build up the red blood cells in their bloodstream, to increase their capacity to reduce fatigue in muscles and lactic acid buildup. So it's a fascinating subject, but very applicable to what we do in dentistry when we're working with airway problems, gastric reflux, sleep apnea, things like that. So the mantra here would be, we're designed to breathe through the nose and we're designed to eat through the mouth. So taping is something that many of us have been working with, and in fact, if we have a patient come in and they say, well, I snore badly and my wife is not happy, we'll do a home sleep study. We'll find out if there's apnea involved. If it's mild apnea or just snoring, our first step would be to tape for 2 weeks. We'll just tape for 2 weeks, and then we'll review or even repeat the study and see what we find. And in many cases, snoring will subside with mouth taping, and sometimes mild apnea will actually disappear. There's different ways. If people are a little concerned about taping their mouth shut, that makes them fearful. Here's an example. These are called chin-up strips, and it actually goes around your mouth and lifts your chin up, and it'll hold your mouth closed very effectively. Breathe right strips are something that can also be helpful in conjunction with this. And some people will actually wear these chin straps if they don't want to tape. So that's another alternative to taping, would be to hold your mouth closed by wearing a chin strap like this that you can get online for maybe $10. So what about occlusion? Occlusion is something that we're obviously very concerned about here at the Dawson Academy, and also all of us that do restorative dentistry and manage patients. And what about occlusion and disordered breathing? We are seeing lots of problems in children today that are the classic mouth breathers. Retrognathic cases, narrow palates, poor breathing, mouth breathing, enlarged tonsils and adenoids. These children have some significant concerns, and if you watch in your adult population, you're going to see folks like the example on the right-hand screen that are the adult example of what you see on the left hand of the screen with children. What about occlusal correction strategies? Well, with children today, it's important to be much more aggressive with these problems of malocclusion that may relate to airway problems. If you have a child that's a mouth breather, if you have a child who has a narrow palate upper arch, if you have a child whose tongue seems enlarged or is coming out of their mouth as they speak or breathe, if you have a child with enlarged tonsils and adenoids, then we want to be very aggressive with this, because it can significantly affect every component of their life, including their cognitive abilities, their fatigue levels. Many children have been diagnosed as ADD because of the symptoms they manifest that relate to airway problems, and I was with a wonderful orthodontist yesterday who was sharing with me that he had a 6-year-old come in who looked very much like this one on the left, and in 3 weeks of palatal expansion, this child completely changed personalities, was delightful, and had been not sleeping well, was sleeping very soundly now, was not tired anymore, was doing better in school, all because of 3 weeks of palatal expansion. And so we're seeing significant things. In adults, orthodontic care is being implemented, and sometimes some forms or degrees of orthodontic surgery may in some cases be indicated. Tom Colquitt, past president, American Academy of Restorative Dentistry, and a dear friend of ours from Shreveport, Louisiana, gave a presentation this past February, at the American Academy of Restorative Dentistry, talking about airway and breathing disorders and occlusion. And he quoted Dr. Bob Ricketts, who is one of the most famous orthodontists in the history of our profession, who said, in 1955, respiration and mastication are biologically inseparable. I was thinking about that comment, and one day I took this CT scan on a patient, and I was looking at this view, and I immediately noticed, look at the teeth on the maxillary arch, and look at the nasal sinuses, and look at the floor of the cavity, and look at the upper arch, and how as we have narrowed arches, we literally can narrow or decrease the airspace above through the nose as much as 50%. And so occlusion, mouth breathing, tongue thrusting, airway obstruction, blowing off CO2, narrow nasal passages, these things all go together. This is oral medicine. This is what it means going forward to be a physician of the masticatory system. And in fact, Tom was so adamant about this as he shared at a table clinic at that meeting with a group of the top restorative, top occlusion-oriented dentists in the whole world. He said, gentlemen, ladies, our new priorities are, number one, that other than emergency care, the first procedure performed by every dentist for every patient of any age should be a proper airway examination and evaluation of breathing function. And secondly, the primary duty of every dentist is to promote proper nasodiaphragmatic breathing for every patient. And thirdly, the teeth are of secondary importance. In other words, if the patient is sick because of airway issues and breathing issues, then we must see that as our highest priority. And the teeth, in that sense, are secondary, even though often occlusal or dental therapies may actually be a large part of the solution. Talking about gastric reflux, very important subject, and you see here that 60% of the adult population will experience some type of GERD within a 12-month period. Less than 15% will ever be screened for that. This is a significant problem because of the fact that not only will 20 to 30% have weekly symptoms, but we're learning now that from the stomach acids that may come up, the pepsin digestive enzyme, along with bile, can escape into the esophagus, into the throat, into the mouth, all the way up in the nasal passages, and even out into the airway, right all the way to the bronchioles and to the lungs, often mimicking asthma-like symptoms. But this escaping from the stomach, especially of the pepsin enzymes, can irritate the mucosal lining of the esophagus. It can be linked to a gastroesophageal reflux disease and Barrett's esophagus and even esophageal cancer, which is the fastest growing cancer in the U.S. So this is a super important subject that is not really being addressed by almost anyone medically except for specialty referral. It's recently been linked to a highly acidic Western diet. The way that works is that pepsin, the digestive enzyme of protein that's produced by the stomach, when stomach acids are released or when they're stimulated, the pepsin enzymes are stimulated as well. When you get those acids from the stomach aspirated into the esophagus, pepsin will go with it, bind to the walls of the airway, causing inflammation and cellular damage, which the inflammation in the walls of the airways is critical to all of these topics. it can be the main cause of airway damage and even cancer. So you can't remove the pepsin by taking PPIs or antacids, and it's not picked up using pH testing. So it's a very serious issue, even causing asthma-like symptoms in the lungs. So the common symptoms of gastric reflux are a sore throat, chronic cough, feeling of a lump in the throat, postnasal drip, persistent throat clearing, voice changes, hoarseness, asthma, earache, and here's a very important one too, silent reflux. So a lot of people don't know they have reflux, but do have reflux, and it's kind of like clenching or grinding, you know, where half of our patients will say, no, I don't think I do that. So here's a critical part for us. One of the earliest signs and most common signs of gastric reflux is erosive dental wear. So when we see on a teenager that 6-year molar on the bottom and we're seeing cupping out in those little islands of dentin exposure, you very well may be looking at the signs of low pH related to gastric reflux. And so we are right on the front lines as far as that goes in screening. So let's do this. Kaufman has a symptom index quiz. You can copy this offline as well. Many medical centers use it around the country. And you can screen your patients for gastric reflux. They simply answer from 0 to 5, add it up. If the score is more than 15, then they have a 90% chance of having reflux in their airway. So simple to do. I would recommend you do that with every patient as a physician of the masticatory system. And here's another very interesting finding, is that there's a connection between gastric reflux and sleep apnea. First time I remember speaking with a sleep physician who was a true expert, I said, I've been reading some things about gastric reflux connected with sleep apnea. Do you see that? And he said, oh yeah, of course, that's easy. You know why? And I said, no, I don't have any idea. And he said, well, that's simple. If you have an obstruction in the throat and you can't get air down, you create a negative pressure, and then you'll get a pressure coming up from the abdomen, and you'll have gases and acids escaping straight on up through that straw effect that occurs because of the blockage. And so he says that explains it. I didn't know that. I thought it was extremely helpful. But then when I read Dr. Kaufman's book about acid reflux and the discussion about diet, the subject of sleep apnea never came up in her discussion, which leads me to think that there's a combination of issues going on here. One is obstructive sleep apnea, and two is the acidic diet that Dr. Kaufman talks about. And so it's sort of a chicken and egg. You know, do you get obstructive sleep apnea because of acid reflux, or do you get acid reflux because of sleep apnea? And the answer would probably be yes. So treatment of gastric reflux. What we do is, if someone is positive for gastric reflux, we do two things. Number one is we'll get them a copy of Dr. Kaufman's books and recommend they read them thoroughly and see if changes in their lifestyle that can help from that perspective, and perhaps seek out a medical referral. The second thing, though, is because we understand the link with respiratory effort and closed airway, and that can pull acids up, then if that's true, we should be screening and testing and diagnosing and treating upper airway resistance and obstructive sleep apnea as part of this, and gastric reflux may be a reflection. So it's a twofold therapy. One is looking at the diet and making modifications appropriately through the guidance of Dr. Kaufman's work and another health professional. And secondly, going ahead and screening and testing and diagnosing whether there's obstructive sleep apnea present. So that's all we're going to be able to talk about today. I want to invite you to follow up with us on this. We're going to have a course January 27th and 28th in St. Petersburg, Florida, through the Dawson Academy on sleep apnea and occlusal splint therapy. So we're going to talk about occlusion, we're going to talk about parafunction, we're going to talk about TMJ disorders, we're going to talk about the connection of those things with airway disorders and breathing disorders, and also with reflux. I've asked Dr. Cole Quitt, who is now leading the LSU sleep dentistry program in Shreveport, Louisiana, along with Mark Farina, who is one of the best orthodontists I know, who is focused on airway and airway orthodontics and has treated many children and adults with airway obstructions and airway-related occlusal type problems. So I've asked them to join me for this 2-day event in St. Petersburg, and I just want to urge you to come because it'll be a dynamic meeting full of great implementation and lots of tremendous insight for you as you expand your model of dentistry. The other invitation I would give you is on this topic of our 4 Bs, the bite, bacteria, breathing, and body, what we're calling integrative dental medicine. We're going to have 2 courses coming up on how to build and I have to use the word profitable complete health practice because so many dentists I talk to are interested in these subjects but don't get engaged in this because they feel like it really doesn't fit into their business model. So we're going to make sure it fits into your business model, and it's something that after this meeting you can go home and produce at least $100,000 more the next year through the different types of services that you can provide for your patients as a result of this meeting. So we have one coming up in 3 weeks, and if that's not too short, we still have about 4 or 5 spots open, I believe, in St. Petersburg. So you can contact the Dawson Academy and come join us, or we're going to do this course again in April here in St. Petersburg on the 28th and 29th. So Sarah, that's all I have to say, and I hope that it's been helpful. If there's any questions, I'd be happy to address them.